Hi, everyone. Requesting everybody. Yeah, thanks. Hi, everyone. Thank you. Thanks for joining and welcome back from lunch. We hope you had a good time speaking to everybody from Gates and Clarendon and all the different research and had a good morning of, meeting people from across different disciplines and meeting fellow Gates and Clarendon scholars. For those who I haven't met, my name is Nithya. I am the Diversity Secretary at Clarendon Scholars Association and also the Phil in Public Policy at Blavatnik. Coincidentally, my own research is also on diversity, and I study diversity and disability. And academic diversity is kind of the theme of what we're going to be talking about today in our main panel discussion. I think diversity is something that I have spent a lot of time thinking about for my own research, as well as while putting this panel together. There are many different facets to it and many different angles to it. But for the sake of today's discussion and today's panel, we are focused on academic diversity and on thinking about how to bridge disciplines within your work, whether you're working at the intersection of different disciplines, whether you're working at the intersection of research and implementation, research and entrepreneurship, and those sort of things. And we have a fantastic lineup of speakers, two of whom are joining online, one from Singapore and one from the US. So we also have diversity in time zones. With the 9 a.m., we have a 2 p.m. and we have a 9 p.m. in Singapore. And we have 3 speakers in person, and we are very excited to have everyone here. And so thank you so much for taking the time to speak with us today. Just quick housekeeping. So how it's going to work is we will have, for Mo and David, we'll be having a 15-minute session where they'll be talking a little bit about their work, and then a 5-minute Q&A for each of them. And then for Nainika, Sonia, and Riyam, who are here in the room with us, we're going to have a panel discussion. So they'll each be giving a 15-minute talk about their work, and then we will have a 30-minute panel discussion here on just the themes of academic diversity and to understand how they've navigated this in the course of their careers. So I think we can get started with you, Mo. So Dr. Mo Yin is currently the Deputy Director of the Advanced ID Research Network, which focuses on conducting innovative and pragmatic large-scale randomized controlled trials for diagnosing and treating multi-drug resistant bacterial infections. She completed her DPhil in clinical medicine in 2022, during which she led a multi-centered RCT to assess the impact of shortening treatment duration for ventilator-associated pneumonia. She has received numerous awards for her achievements in clinical care, and her career goal is to serve her community, focusing on translational research to influence regional and global policies. Dr. Mo Yin, welcome. Thank you for joining us from Singapore at 9 p.m. And the floor is yours. Thanks.
Thank you for the very kind introduction, and thank you to the organizing committee and Yalda for inviting me to this exciting event. Today's talk, I'll be focusing on a personal journey on how I started on research, how I ended up in Oxford, and what I'm doing today. And the focus is on antimicrobial resistance with a very global health perspective. So this is me in my scrubs in the hospital more than 10 years ago now. So I attended medical school in Singapore and did my residency there. And during residency, I started to get really involved in research because I wanted to sort of spark change in healthcare, especially in low middle income settings, that is sustainable. So at that time, I joined a lot of NGOs and various other efforts going to neighboring countries in Southeast Asia. But my conclusion at that time was research was probably the best way, in a sense that it is objective, almost an objective form of journalism where we can shed light onto important issues and present evidence to policymakers to bring about sustainable change. So this is the first trial that I was involved with as a general medicine resident. This is the Merino trial, where we compared piperacillin tazobactam versus meropenem for patients with resistant bacterial infections. Not to not to worry about these big terms. These are just two of the very broad spectrum or last line antibiotics that we typically give our patients interchangeably before this trial for these resistant infections. But this trial was terminated early, which was a big surprise to all of us as clinicians. Because it clearly showed that piperacillin tazobactam was not non-inferior to meropenem. And that almost overnight changed international clinical practice guidelines. And that also impressed on myself that the power of research, and without research, we may be hard knowing. So then I became very interested in antimicrobial resistance. Actually, 2024 was so-called the year of AMR, or antimicrobial resistance, because UN and multiple high-level political meetings were held to discuss this issue. By WHO, is regarded as a top 10 global health, public health issue. And in Asia, where I live, bears one of the biggest, highest burdens. And of course, it causes a lot of deaths and a burden of disease in both community setting and hospital settings, and even in high-income settings. It can jeopardize modern medicine advancement in terms of surgeries and cancers and transplants. So of course, at home, I was also seeing patients who were suffering from these type of infections day in, day out. So for example, in this 53-year-old man who had kidney failure for 10 years, finally got a transplant. But 1 week after the transplant, he got these 3 bacterial infections that's resistant to almost all antibiotics that we had. And the only susceptible or sensitive antibiotic that we could use was highly toxic to his kidneys. So in the end, we saved his life, but his new kidneys didn't survive. So he went back on dialysis. So not just in high-income settings like in Singapore, this is causing a problem. Antimicrobial resistance is really both a driver and symptom of inequity. And UN here have highlighted that it can really aggravate extreme poverty. So then I decided to do a PhD, and where I decided to do that was actually in Bangkok. So Oxford actually has a tropical medicine unit or network spread across Asia as well as in Africa. And the reason why I moved to Bangkok was that because they already have a existing research network that I thought I could hinge on to build a clinical trial. And also it's in the middle of Asia, where culturally and in terms of language, and I'm the closest to. So during the PhD, actually before my PhD started, I had this idea of tackling a low-hanging fruit in antimicrobial resistance, which is to better define duration of treatment for antibiotics. I'm not sure how many of you in the audience have been told that by doctors that you should finish your antibiotics when you're prescribed. But actually, if we really think about it, all of us carry 1 to 2 kg of bacteria in our gut, on our hair, on our skin. And no matter how much antibiotics that we take, that's meant to kill the pathogens, they will never kill these healthy bacterial microbiome on our skin. So there's detrimental effects on these bystanding, colonizing bacteria on our skin and our gut while we are trying to kill the pathogens. So actually, in terms of antimicrobial resistance, it makes sense to stop antibiotics, unnecessary antibiotics, early. And I thought if I can prove this concept in very, very sick patients in low middle income settings with very severe infections, then I can help to change the paradigm of thinking in terms of duration of antibiotic treatment. And so there came the REGARD VAP trial. So we enrolled patients that fulfilled the US CDC criteria for ventilator-associated pneumonia that's typically seen in the intensive care setting. And we watched patients for clinical stability after being treated with appropriate antibiotics. So that meant that fever has gone away for 48 hours and blood pressure is stable. Then we randomized them to stop antibiotics immediately, as short as 3 days, or continue the antibiotics according to physician preference to more than 8 days. And we wanted to look at the 60-day mortality or pneumonia recurrence. And so then I had to move to Northeast Thailand. This is the hospital there, the Sampasit Hospital with a very nice lake, to start this trial. And that was my biggest trial site. And I remember being there for the first day. A very senior physician told me that you will never be able to do this trial. You need to go home. You don't speak our language. You're not from Thailand. And who are you to come here and stop antibiotics for our sickest patients? And I remember presenting the protocol to a room of medical doctors, 44 of them. And one of them stood up to yell at me, basically saying the same thing. Who are you? And why should we do this with you? So I stayed there. Instead of packing up my bags, I brought my bags there, and I stayed there, learned the language, and saw patients with them in the intensive care units, and convinced the doctors one by one to participate in my trial. And at night, when I've stopped seeing patients and convincing people to join my trial, I actually looked at the problem of non-adherence in clinical trials, especially in non-inferiority trials, which is a very commonly used design these days. Because when the physicians participating in the trial is non-compliant to the protocol, we reintroduce confounding into the trial, and that diminishes the strength of randomization. And so basically, I was doing a lot of trial simulations, writing up our Shiny app, and publishing these results in peer-reviewed journals. And this was really an issue that came up because of this real-life experience of conducting the trial. It was not planned in the beginning of my PhD, when I didn't realize there was going to be such resistance against participating in my trial. And even after the physicians agreed to participate in the trial, there were so many cases of non-adherence. So after living in Thailand for quite a while and learning the language, there were more and more enthusiasm about participating in the trial. So then I went to Nepal and made even more friends. So in the end, we had 39 ICUs in 6 hospitals from Nepal, Thailand, and Singapore participating in the study. And this was a really great opportunity because we had such a diverse mixture of social economic settings participating in this study. And through doing this study together, we managed to, in our little network, we managed to do a lot of capacity building in terms of data collection, in terms of ensuring quality of data that's collected, and also conducting additional qualitative studies. So there were a lot of opportunities for local research personnel and nurses to gain new skills. And so after screening for 11,000 patients, we completed a trial, and this was no easy feat because we survived through COVID, where one of our principal investigators in Nepal was in the ICU himself. And amazingly, we achieved over 95% of adherence to the protocol after engaging with local teams over the years and gained a lot of trust from them. And this just very quickly going through the results. In the short duration, the duration was as short as a median of 6 days versus the standard of care of or the usual practice of 2 weeks. So we did manage to cut down antibiotic use by quite a significant number of days. And when we look at the primary outcomes in terms of deaths as well as pneumonia recurrence, you can see that the lines really merge very well after 60 days. So there was really no difference between short and long strategy. So this trial was published in Lancet Respiratory Medicine last year, and fortunately, it did gain quite a bit of interest from both intensive care physicians and infectious diseases community, and hopefully it can contribute towards international guidelines on duration of treatment. So then, after spending 1.5 years in Oxford, in Thailand and Nepal, I moved to Oxford. But on the day that I moved to Oxford, I'm not sure if you remember this guy over here. He's prime minister, many prime ministers ago. I've lost count. So he announced a lockdown. And so I had to pivot my research from antimicrobial resistance to COVID, as with everyone else. And during this time, I worked with Public Health England to look at hospital transmission of COVID. So we realized that there were a lot of COVID cases in the nursing homes and hospitals, and who's driving those infections. And through a lot of, I think there was 70,000 admissions in this paper that were included, we realized that who's driving infections within hospital setting were not healthcare workers, were not patients coming in with COVID, but other patients who were infectious with COVID but came in for heart attacks or strokes or other reasons. So these patients were not properly isolated and they were spreading COVID within hospitals. So that led to the policy change of screening for COVID amongst non-COVID patients during hospitalization. And I also worked with WHO at that time to lead a healthcare worker study that involved 21 countries and enrolled over 5,000 healthcare workers to look at what's the appropriate personal protection equipment to wear to prevent COVID infection. So then I graduated, and that's my lovely mom over there 3 years ago from Oxford. And I moved to Singapore to lead Advanced ID. So during my PhD, I had the privilege of setting up a small research network. And Advanced ID, which stands for Advancing Clinical Evidence in Infectious Diseases, is a much larger network that we established over the past 3 years. It is a warm network, meaning that we have active studies happening across the network in terms of observational and interventional trials. And most of these hospitals are in low middle income settings. You can see here that I haven't been in Singapore much in the past 3 years. This is Nepal, China, Vietnam, in Malaysia, the Philippines, Mongolia, Sri Lanka, and Thailand. And so we've been everywhere, mainly in Asia, through standardizing our protocols. We do a lot of capacity building work. And by collaborations, we enroll a lot more patients and more efficiently. So this was our launch symposium 2 years ago. You can see just about 1 year into the network, we can already see so many investigators came to Singapore to support us. And now it has grown to over 500 collaborators. And very quickly about what we do. So antimicrobial resistance is everywhere. Everyone sitting in the room probably has been in contact with a resistant gene or resistant bacteria. But who is really suffering and dying from these infections are patients in the hospital setting. They are usually sick patients with a lot of comorbidities, and they go into the hospital and they contract these infections and they suffer from pneumonia and bloodstream infections. And therefore, our main strategy is to tackle antimicrobial resistance in the hospital setting. And we started off by quantifying the disease burden. And through that, we built research capabilities across Asia. And then the next step, we are strengthening diagnostics so that we can diagnose these infections faster and more accurately. And then we are doing work and trials to improve prevention of these infections, and also doing work to do a better stewardship of antibiotic use. And we are also starting a big trial to optimize antibiotic treatment. So these are the various projects. And so this is the first observational project called ACON-HAI that we just completed enrollment for. And in a short span of 2 years, we enrolled over 10,000 patients across 19 countries in Asia. And you can see dark purple over here means that the resistance to last-line antibiotics in a very common bacteria is more than 80–90%. And we can see in the WHO categorization of antibiotic use, red and orange means they are dangerous, ineffective antibiotics, but more than 80–90% of our patients in Asia are receiving those really terrible antibiotics because we do not have access to newer effective antibiotics. And when we look at mortality, generally the overall mortality was 40–50% in these resistant infections. And if we were to eliminate this resistance, we can easily reduce this risk by the 17–13% if we can prevent this resistance from emerging. So of course, doing all those kind of studies can lead to big papers and big journals and that's a very fairly robust study. But while doing such work, we also kept our connections with the study sites very close, and also wanted to use the data to feed into local policies as quickly or as quickly and as effectively as possible. So this is an example from Medan in Indonesia. So through doing the ACON HAI study, they realized that their blood culture contamination rate was as high as 43%. And through their own effort, they managed to reduce that to 14%. And in Cambodia, they were trying to set up an infection prevention control unit for 20 years, but failed to do so because of funding issues. But because of ACON HAI project, they simply multiplied the number of cases they detected through the project by $3,000 and showed to their administrators they can save up to almost $1 million by investing in such a unit. And they did manage to set up such a unit within 1 month and reduced their hospital-acquired infection rate from 24% to as low as 5% in just a span of 2 months. So I think I may be going over time, just a couple of slides more on some other trials that we are doing. So we are tackling with very highly resistant bacterial infections in Asia that we found in ACON HAI. And this is carbapenem-resistant gram-negative infections. And we are using very innovative trial methods through using these pragmatic designs and innovative Bayesian analysis approaches to make such large pragmatic trials possible across Asia. Yeah, and that's my last slide already. Thank you for your attention, and I'll welcome any questions.
Dr. Moyen, thank you so much for sharing that. It's fascinating to hear, and I'm sure it was very challenging to do this, finishing your PhD during COVID and pivoting your topics. We have time for one question. Does anyone have any questions for Dr. Moyen right now? Great. So, I mean, I have a question because I'm asking for my own personal research as well. How did you know when to pivot from something that's not working and know that the marginal utility you're working on that has decreased? And so how do you make that decision, and at what point?
It's a good question. I think I'm known for not giving up on things. Many people have told me to give up on the trial during my PhD. My PhD supervisor also advised me to have a deadline for myself. But it was really through tenacity and working closely with the ground that made it possible. I think at the heart of what we do in research, and especially for myself, is in bridging inequity in health. And with that comes with empathy, understanding with the issues on the ground. Of course, it's very frustrating to go to a different country and design all these trials and apply for all these grants. And in the end, people ask me to go home. But there are issues on the ground. There's always compromise that we can reach, always issues that or differences that we can bridge to achieve an ending that's beneficial for everybody. I don't know if I'm really answering the question, but for clinical trials and large collaborative projects, that's usually the case. But of course, given our best effort, if things are still not moving or the other party is not motivated, then it has to end somehow. Yeah.
Great. Thank you so much for joining. And of course,